Good morning, respected faculty and dear delegates. On behalf of IP Delhi, I welcome all of you. Today we have Dr. SIDHARTH Sethi and Dr. Rupesh Rana, who will be expert and the speaker for the day. And we are fortunate to be joined by Dr. Dheeraj Shah, Principal of University College of Medical Sciences in JTB Hospital. We welcome you, sir. I request Dr. Neha to please introduce the expert and the speaker.
Okay.
And before that, I request Dr. Dheeraj Shah sir to say a few words.
So thank you, Dr. Ajay. As we all know that we are discussing a very important topic, acute kidney injury, which the definition has very much widened. So it's very important for pediatricians to understand when to intervene and when not to, when to seek the consultation of pediatric nephrologist. And also very early, do all that very early, because sometimes time is a critical factor when you say diagnose or when you manage acute kidney injury. Sometimes in rapidly progressive glomerulonephritis, it may be a matter of few hours and days then when the nephrons may undergo a permanent damage which may be irreversible. So I think it's a very important topic. The definition, the causes are very wide, and we have eminent experts, our own Dr. SIDHARTH Sethi, who is now a consultant in SIDHARTH, you are with
Artemis.
You're with Artemis. Okay,
Yeah.
great. So Artemis Hospital, and we have Dr. Rupesh Raina. Thank you, sir, for staying, I would say joining, despite it being very late in US. Your commitment is exemplary. And I'm sure that today's discussion will enrich our postgraduate students, our general pediatricians, as well as those with an interest in pediatric nephrology, to diagnose this condition early, to early intervene, and if referral is required, to refer early so that I would say permanent kidney injury, what we call as a chronic renal damage or chronic kidney injury, doesn't happen. So I open this discussion. Thank you, Dr. Ajay, Dr. Neha, for.
Good morning, ma'am. Good morning, sir. Good morning.
Thank you, sir. Thank you. Welcome, Dr. Dinesh.
Good morning, sir. Good morning.
Good morning.
Sir, Wall.
Yes, the session is already started, I think. So pass over to Dr. Neha. And on the behalf of IIP Delhi, I welcome you all, especially Dr. Dheeraj Shah for sparing time in the morning, Dr. Rupesh Rana, and Dr. Today's speaker, Dr. SIDHARTH Sethi. Please hand over to Dr. Neha.
Thank you, sir. Thank you very much. Welcome all to IIP Delhi eNephro course on pediatric nephrology. And in this exciting session where all our delegates are very excited to hear from Dr. SIDHARTH Sethi, first of all, I would like to introduce our expert, Dr. Rana. So Dr. Rana doesn't need any introduction. I think all around the globe knows him so well. Sir is a adult and pediatric both nephrologist. And he's currently practicing in Cleveland Clinic. He's AGMC, Cleveland, Ohio. And he's also doing staff and fellowship, staff Summa Health Nephrology ICU. He's also in the Academic Advisory Council of Rebecca D. Considine Research Institute. And he's also staff at Akron Children's Hospital. There are so many publications under his name. He's also Director, College of Medicine, Office of the Dean, and Medical Education at Northeast Ohio. Sir, welcome. And I think it will be very, very enriching experience for us. And thank you. As Dr. Shah mentioned, it's exemplary that at 11:30 you have joined us. So really looking forward to have expert comments from you. Then I would like to welcome our speaker for today, Dr. SIDHARTH Sethi. He also doesn't need any introduction. I think he's one of the pioneers of pediatric nephrology in India with more than 200 publications in index journals. He's also currently a consultant at Artemis Hospital, Gurgaon. He has written a book on critical care nephrology. His areas of interest is AKI. He's one of the pioneers who is doing a lot of work in Neonatal AKI. He is also on the board of directors of PCRT Iconic Foundation. He has been awarded for outstanding contribution to pediatric nephrology, Case Western University, Cleveland. He is also an Indian ambassador of pediatric nephrology for International Society of Nephrology. So welcome, sir. Let's not waste time and just hear from you. Over to you, Siddharth, sir.
Thank you. Thank you, Dr. Neha, for the kind introduction. And it's an honor to be here. And I think most of you were not aware that I did my MD Pediatrics from UCMS. And it's an honor that Dr. Dheeraj Shah is here. He has been my mentor for more than 20 years. And it's also an honor that Dr. Rupesh Rana is here. He's like my brother and also a mentor. And we have done a lot of work in academics in this area in the last 2 decades. So what I'll do over the next few minutes is I will tell the recent advances and what all postgraduates and pediatricians need to know about AKI. So I'll keep on talking about what basic they need to take home. So let us start with a common case in our hospitals, a 10-year-old boy who comes to us, and this 10-year-old boy has oliguria, puffiness, cola urine. He has hypertension and has evidence of pulmonary edema. He has a high blood urea and serum creatinine. He has hyperkalemia, and so this is definitely acute kidney injury, and especially for the postgraduates, when you have a child with cola urine and hypertension, azotemia, you should think about a nephritic syndrome. So this looks like like Dr. Dheeraj Shah just told you about, a rapidly progressive renal failure. So we definitely know it's a severe AKI. Now, this is another child, a neonate who had a severe HIE at home, and his urea creatinine are high. He has hyperkalemia, metabolic acidosis. So again, this is a very common AKI in newborns, post-asphyxial AKI, and we will talk about it. So let us talk about the definition of AKI first. And especially for students, see, definitely in your exams, you are asked about the definition of AKI, and you should mention that the most commonly used, the current definition is KDIGO. So we used to use, there were two more definitions called ACIN and P-rifle. They are basically the same. However, you should know that KDIGO is the standard of care nowadays, and it is used in children and adults. And stage 1 is a rise of serum creatinine 0.3 or more within 48 hours. And remember that there's a lot of evidence on this from adult literature that if there's a rise of 0.3, these patients have more mortality, more hospitalization, more length of stay in the hospital. Or if you don't have a baseline, then you can say from the baseline when the patient came to your hospital, 50 to 99% rise, 100 to 199% rise, and so on. Now you can see if a patient is on dialysis, we definitely say that this is stage 3 AKI. So AKI is defined as a rise of serum creatinine or reduction in the urine output. So if the urine output is less than 0.5 ml per kg per hour for 6 to 12 hours, it's stage 1. It's stage 2 for 12 hours. And if it's persistent anuria or severe oliguria, that's called stage 3. So they're essentially the same. Now, if we compare these definitions, remember all definitions are fine if you are using them, but remember KDIGO is the standard of care, because all definitions, whenever we use definitions, they correlate with the mortality, the length of stay in the hospital, and they have a very good interstage discrimination. So what I mean is that if a patient has stage 3, he does worse in the hospital as compared to stage 2, as compared to stage 1. P-rifle is a good definition. It is a sensitive definition. It diagnoses more stage 1 cases. There was a previous definition called ACIN definition also, which was a more selected definition, more of a research-based definition, which does not include a baseline. So remember that still for you guys, KDIGO should be used. Okay, so KDIGO is the definition which we use for everybody. It is less restrictive, and you can use it in research also, and it is an excellent definition. Now, why are we talking about AKI today? And all of you would be saying, why should we think about AKI? You know, if you look at neonatologists, a lot of neonatologists don't even talk about AKI in their conferences also. But I would like to tell you that AKI is a very important area to be discussed about, because if you look at this study from the AKI advisory group, it clearly says that 1 in every 5 adult and 1 in every 3 child during the hospital stay develop AKI. Okay, so it's quite common. So what are the causes of pediatric AKI for the medical students here? We divide the definition into pre-renal or a functional AKI, intrinsic AKI, when you have definitely there is a damage to the kidney tubules or the glomeruli, or post-renal when there is an obstruction. So pre-renal is the most common. Okay, so you look at any textbook, whether you look at Harrison's textbook for adults or Nelson's for children, pre-renal is the most common, and it is mostly because of volume depletion like shock, diarrhea, or it can be peripheral decreased cardiac output, which can happen in CHF, or peripheral vasodilatation or renal vasoconstriction, which can happen in septicemia AKI. Now, intrinsic AKI, if the functional AKI is not well managed, it can go into acute tubular necrosis. There are vascular causes, even microvascular causes like HUS, which we'll discuss about some other day as a different lecture. Interstitial disorders, glomerulonephritis, and we always need to rule out obstructive causes. So whenever a patient of AKI comes to you, definitely you need to rule out obstructive causes. Remember, when you have a patient with AKI, urine examination is very important, and you need to look at the WBC CAS, muddy brown CAS, or you have the RBC CAS, which definitely show that this patient has glomerular injury. So remember, urine examination is the heart of the investigations, and your first lecture was on urine examination. Now, we do kidney biopsy only if needed. So if you have a patient who has unexplained AKI, so if you have a patient, you don't know the cause of AKI, he's got severe AKI, you do a kidney biopsy. So for example, this patient came to us and we had no cause for the AKI. We did a kidney biopsy here, and you can see a lot of blue, completely blue looking core. And when you look deep into the kidney biopsy, you can see a lot of even eosinophils in addition to the other WBCs. So it was an acute interstitial nephritis, and that child had taken some indigenous medications from Babaji also, and he got severe acute interstitial nephritis. Now, another biopsy, this patient came to us with rapidly progressive kidney failure. So students, if you have a patient who has deterioration of the kidney function over days to weeks, then also we do kidney biopsy. Okay, because if you, and even on the light microscopy, you can see that there are some crescents in the biopsy. So, and this is almost a fibrous crescent encircling the glomerular loop. So this is a crescentic glomerulonephritis. So you should do a kidney biopsy if you're suspecting a rapidly progressive kidney failure also. And of course, if the kidney biopsy should be done, if there is not improvement of the AKI, you're suspecting ATN, suppose a patient had shock, and over the next 2 to 4 weeks, the patient has not improved. So then also we do a kidney biopsy. We do a kidney biopsy if a patient has nephritis with systemic disorders like Henoch-Schönlein purpura, now called IgA vasculitis, or lupus nephritis. Now, coming back to the causes of AKI, it also depends on the demographics. So if you look at this study from Kenya, infections were most common cause of AKI. A study from United States, so what has changed in the developed world is that, or the more researched nations, is that most common cause of AKI are now post-cardiac surgery, post-hemato-oncology, post-transplantation. While in India, we have more of, I would say, we'll start from pre-renal causes and acute tubular necrosis, followed by hemolytic uremic syndrome as causes of AKI in India. So in India, over the last few decades, you can see diarrhea has, of course, improved with our knowledge about ORS and hydration. But remember, HUS and infection-associated ATN are common causes of AKI still in our part of the world, followed by glomerulonephritis and some other obstructive causes. But remember, infections and HUS are common causes in our part of the world. So I'll start from the conceptual model of AKI. So before a patient goes into failure, like Dr. Dheeraj was talking about, that we need to diagnose AKI early. So this is a conceptual model which talks about, ideally we need to find a child who is at risk of AKI, and we need to intervene here before he goes into damage and reduction of GFR. So who is at risk? So of course, as pediatricians, all of us are aware that if a patient is serious, he's more likely to have AKI. So this is study from Texas Children's, where they showed if a patient is very sick, ventilated on inotropes, then almost there's 82% chance of AKI. Another study from Montreal Children's, if you look at all the PICU admissions, almost 18% chance of AKI. And a study from LA, where again they looked at all the PICU admissions. So more sick is the child, definitely there is more chance of AKI. Now, this is a recent meta-analysis. I'm sorry, this was for students here. We will tell you today 3 important studies which you need to be aware about. This was a multinational, prospective, 3-month study only, which looked at the ICU admissions in the US. And they found that if a patient is admitted in the ICU, a child, the risk of AKI is around 27%. And can you see here, this is the Kaplan-Meier showing if a patient gets 3, he's more likely to die as compared to stage 2 and as compared to stage 1. So there is a lot of distance here, which shows that, of course, stage 3 has more odds of dying. And severe AKI was almost 11%. So students, you should be aware about some landmark studies. Now, this was a recent meta-analysis which again looked at the incidence of AKI in the hospitalized children, which shows again the incidence is exactly the same, 26%, and AKI associated mortality. So, we always say if a patient is sick, he gets AKI. But remember that now we say that AKI is a cause of mortality. Patients die of AKI. So it is AKI related mortality is almost 11%, more so in the low income and the low middle income countries. It's common after cardiac surgery. So a study showing that children who undergo cardiac surgery, the risk of AKI is around 36%. And more complex the cardiac surgery, or if it's done in a neonate, there is a high risk of AKI, almost 64% here in neonatal AKI, neonates who undergo cardiac surgery. So let's take you now to non-critically ill children. So students, you would be thinking that we are only talking about serious patients here, but AKI is also common in the wards. This is a study from Texas Children's, where they just looked at children who received aminoglycosides in the ward for more than 5 days, and they found whatever definition you use, Akin, P-rifle, K-digo, the risk of AKI is almost 20 to 30%. And the more risk is if a patient receives more aminoglycosides in the previous past, or the patient has already a risk of getting aminoglycoside related AKI. Now, more nephrotoxins we use, more is the risk of AKI. And it's very common in NICUs. In NICUs, your patient has PDA, he's on ibuprofen, he's on furosemide. So more are the number of nephrotoxins, more is the risk of AKI. So this was again a retrospective study done by Goldstein and et al., where they showed that the number of nephrotoxins lead to more incidence of AKI. Now coming to neonates. Now again in neonates, whatever population you talk about, very low birth weight, sick, septicemic, asphyxiated, all of them have a high mortality as compared to not having AKI. And you can see that extremely low birth weight, septicemic, asphyxiated AKI, they all have a high mortality and prevalence of AKI. Now, I'll not take you to a busy slide, but I want all of you to know, and you all as pediatricians are aware, if a newborn has birth asphyxia, a newborn is exposed to nephrotoxic drugs, maternal nephrotoxins, needs intubation at birth, needs vancomycin, aminoglycosides, there are more risk of AKI. So I was talking about landmark studies. So students, you should also be aware about this landmark study called AWAKEN, It was a multi-center, multinational observational study on neonates. It was done in 4 countries: Australia, Canada, India. So my unit and along with the Cloud9 group of hospitals was part of it, and this was published in Lancet. So what we did almost 12 years back was that all newborns who receive IV fluids for 24 hours, just a simple definition, any neonate in your hospital who needs IV fluids for 24 hours has a risk of AKI, almost again 27%. More preterm is the child, higher is the risk of AKI. So if a baby has extreme prematurity, there is a high risk of AKI as compared to a term baby. So we've been looking at this since almost now more than a decade now. So we are doing a multi-centric study still, and we are about to publish our consensus also about what causes AKI in newborns in our part of the world, and what are the risk factors, what we can do in our part of the world. So we call ourselves as we are all part of a PCRRT iconic group, which looks at AKI and critical care nephrology all over the world. And in India, we call it as Tinker study, the Indian iconic neonatal kidney educational registry, where we are looking at multicentric causes of AKI. And I'll take you to that. So we talked about identifying is important. Let's talk about risk stratification. So students, you must have seen, the patient, once he comes to the emergency, we risk stratify whether the patient needs to go to ICU or he needs to go to the ward. Now for AKI, we have 2 risk stratification scores. One is called RAI, Renal Angina Index, which is used for children more than 3 months. So what it does is that suppose a patient comes to you in the triage and he is PICU admission. Okay, you give a score. If it's a stem cell transplant admission, you give a score. He's ventilated, you give a score of 5. And you multiply it with risk of injury, which is higher fluid overload or reduction in the estimated creatinine clearance. So suppose he's fluid overloaded, you give a score. So you can see minimum score is 1, maximum is 5 multiplied by 8, 40. So higher is the score, higher is the risk of AKI in the subsequent days of admission. And we know that it is proven now. So remember, this is for more than 3-month-old. So renal angina index, if you look at just any of fluid overload or reduction in the creatinine clearance, if you look at any of them, okay, there is a high chance that they will go into AKI. You can see that this is called the area under the curve, and you can see that there is a very high chance of them going into AKI. It is even better than the illness severity scores which we use in our hospitals, like PRISM scores. So do think about RAI in your hospitals for more than 3 months. Now, what we have done as a group, we have developed a score called STARS, named after the developers. It also includes Dr. Raina, who is here, and it also includes the neonatologists. So we published this in Pediatric Research, and we showed that if you just have 10 parameters, just a score, simple score, 10 parameters, out of this only one is a lab criteria, serum creatinine at admission, and rest are just age, simple parameters. And you can find that if a score is high, more than 31.5, there is a high chance of AKI with a very good area under the curve and very good accuracy. And it can also predict dialysis, peritoneal dialysis also in newborns. So students, I said RAI score for more than 3 months, STAR score for newborns, and I'm also happy to share with you that now there are multiple studies across our country. There are multiple theses going on in our country. There are multiple studies. We recently had a publication from Chile, another study from Europe, which are even right now there's a study from United States also trying to validate this. So we have made a drop-down score on our website on the PCRRT. It's a drop-down menu, just a dashboard where you can just put your patient's age and the demographic parameters, and you can find the score. So if the score, remember, if the score is less than 31.5, you can send the baby to the ward. But if the score is more than 66, there's a high chance of him needing peritoneal dialysis. Okay, so we have validated that for peritoneal dialysis also. and there are multiple conversations about this in the nephrology world. So we talked about identification, we talked about risk stratification. Biomarkers are important, but remember they are costly, so we don't use biomarkers. But you may use biomarker in one-off patient, and I'll tell you which patient today. Preventing damage. So if a patient has AKI, which we have defined already by KDIGO scoring, try to prevent nephrotoxic agents here and try to diagnose fluid overload here. So students, now we have a new parameter called fluid overload. So let me show you this definition first. So if you have a patient in the ICU, you should look at fluid overload every day of the ICU admission, the cumulative fluid overload, which is defined as, there are multiple definitions, but the most common is total fluid in liters and out in liters divided by the admission weight. So fluid overload is now a new vital sign, because we know higher is the fluid overload, higher is the mortality in these patients. So you can see beautifully, if a patient already comes to you with more than 20% fluid overload, he's already in for mortality. So we need to diagnose this early, especially in patients with AKI. Now we did a study which we published in Frontiers few years back, where patients were not having AKI. They were not on dialysis. Okay, and we found that, see, AKI occurs within the first 7 days of ICU stay. Mortality occurs within the first 7 days of ICU stay. And now we also found that fluid overload also happens within the first 7 days of ICU stay. And these are patients who are not on dialysis. They are not having AKI. They're serious patients just. So it impacts the oxygenation. Fluid overload impacts the oxygenation of these patients, and higher is the fluid overload, higher is the correlation with the need for oxygen. So remember, fluid overload, these patients definitely need more oxygenation therapeutics in these patients. So this is what I was talking about, that what we have done in NICUs, or if you talk about PICUs, you first do a risk assessment. And this is also done in adults. Suppose an adult needs a angiography today. So there is a score for that also called Thakkar score, where they do a risk stratification. And in these patients, you limit the nephrotoxins, avoid the nephrotoxins, hemodynamic support. In these patients, you may use one biomarker like urinary NGAL, only one, which can increase your positive predictive value. Avoid fluid overload in these patients. And these are the patients who may need early RRT. Okay, so these patients may need early RRT. So students, we talked about fluid overload. Remember, once a patient is in AKI, nutrition is very important. And remember that drug dosing modification is also important. And I am sure all of you have Harriet Lane textbook with you. Always, whenever you have a patient of AKI, try to calculate their estimated GFR and dose them according to the GFR. Okay. So before I go further, I'll just show you a cartoon that every patient of AKI, definitely you need to look for fluid overload. Then they get dilutional hyponatremia. So for dilutional hyponatremia, usually in established AKI, we just put them on insensible losses. Okay, insensible losses plus urine output. So the treatment of dilutional hyponatremia is mostly fluid restriction. If they get symptomatic hyponatremia, then we give 3% saline. Otherwise, we don't use 3% saline, only in symptomatic hyponatremia. Now for hyperkalemia, we are all aware about agents for hyperkalemia. Remember, if patient has ECG changes, we give calcium gluconate also. Now remember, for hyperphosphatemia, we use phosphate binders, mostly calcium carbonate or calcium acetate. So mostly calcium based here. Now, if you look here, metabolic acidosis is quite common. And for metabolic acidosis, initially we use medical therapy, we use bicarbonate. Okay. For hypertension, avoid ACE or ARBs in AKI. So usually we start with the agent like calcium channel blocker like amlodipine, and if they need more agents, then we add on other agents like prazosin and so on. So nutrition is important aspect, and almost 10 years back in pediatric nephrology, we published our recommendations for nutrition. And remember that we need to give them energy. They need energy, so we should give them energy which should be 20 to 30% above the basal needs. We don't, as pediatricians, we don't, restrict proteins, so we should give them 2 to 3 gram per kg per day. And if they're on RRT, we give them more proteins. Okay, and they need water soluble vitamins as per their need. So remember, nutrition is an important aspect. Now coming to dialysis. Now, when do they need dialysis? So remember, we use dialysis if, so initially, I just showed you the 7 complications just now. Now remember that we go for dialysis if they are refractory. Okay, refractory fluid overload, refractory hyperkalemia, refractory, so metabolic acidosis. So these are the most common indications: refractory fluid overload, refractory hyperkalemia, refractory metabolic acidosis. Then there are some inborn errors as well, which we see, like hyperammonemia, where we also go for dialysis. So the options we have are PD, intermittent hemodialysis, and in patients who are very sick, and if they can afford, it's a continuous renal replacement therapy, which goes on. It's a blood-based therapy only, but it goes on over 24 hours. So it depends on patient size, which modality to use. In sick neonates, we can use PD or CRRT. If a patient is bigger, older, hemodynamically stable, we use hemodialysis. So in hemodynamically stable patients, we use hemodialysis. Otherwise, we use PD or CRRT. And it also depends on your expertise. See, if you don't have CRRT, if you don't have hemodialysis, use PD. Dr. Rupesh in the chair today, and Dr. Bunchman, they always say you need to do what you are good at. So guys, if you are in Rajasthan today, if you are, say, in the just has PD, you do PD. Okay, you do what you're good at. Okay, so of course, if you have a stiff PD catheter, you use stiff PD catheter. But now remember that soft tank-off catheters are here. This is a soft tank-off catheter with a trocar and a dilator, which are now available. They, if possible, you should use softer catheters. They have decreased risk of infections, no reinsertions needed. So you can use it for months also. Okay, so all of us have moved on from stiff catheters to softer catheters. Softer catheters can be attached to a home choice machine, with which you can, attach 15 liters of PD fluid. You don't need to touch the patient also. This machine also warms the fluid to the body temperature, so avoids hypothermia also in these patients. So there are ISPD guidelines for PD, and which clearly say, if possible, you should go for a tank-off softer catheter, which you can insert bedside also using the same Seldinger's technique which all of you use. Okay, and remember, there are size for tank-off catheters available. You may use 1 dose of prophylactic antibiotic just prior to the PD catheter insertion. That's it. So there is another modality called a slow hemodialysis, and we have published multiple research papers on it, that you can use a slow hemodialysis also in older patients, which is called SLED, a sustained low efficiency daily dialysis. So if your patient is very sick and you don't have a CRRT machine, you can use a slow hemodialysis using the same hemodialysis machine, but it is usually used for children more than 8 kg. Now students, you may get even and I know that the DNB theories are becoming more and more difficult nowadays. So you may get a question on, say, what's new in AKI. So you may also talk about, that there are some new machines coming up made for children. See, hemodialysis machine, which you must have seen, is not made for a child. Now we have new machines which are made for children, which have very less errors. And the first machine which came from Europe, developed by Dr. Ronco, is called Carpe Diem, called the Cardio-Renal Pediatric Emergency Dialysis Machine. So this machine is now available in the United States also, in Europe also, and all the centers are slowly being trained. And it might come to India very soon, and this got published and got made after the initial studies from Dr. Ronco on using it on newborns also. Aquadex is available in the US. It is also available in India also. Aquadex is basically a slow water removal machine, a slow continuous ultrafiltration machine. So, even in our country, if you have an adult with refractory heart failure, people use Aquadex. So Aquadex is, I would say, mostly a machine to remove water. A SCUF, slow continuous ultrafiltration machine, which is also available in India, but you can, I would say, use it for water removal only. Okay. Now this is a machine from UK called Nidus, but it will take some time to come because there are some issues in the development in the UK for this. It's called the Newcastle Infant Dialysis and Ultrafiltration System. It's just like exchange transfusion. It has a very small circuit of 5 ml. You can use it in newborns. It is a single needle machine, has a syringe control, and Dr. Malcolm Calthorpe has also published that this machine has a very good, it is error-free machine. If you use Nidus as compared to Carpe Diem, as compared to the other machines, so all of these machines are made for children. So they have very good, they are more precise as compared to the other machines. So today we talked about identification of AKI, risk stratification of AKI, preventing damage. We talked about fluid overload. We also talked about the common complications which you anticipate in AKI. We talked about nutrition, dosing, need for RRT, when to use which modality. And remember, you also need follow-up of these children. There are multiple studies. These are all studies which talked about following up these children. This is the only prospective study here from a friend from Vancouver. And what we have shown in all of these studies is that all of these patients have a risk of proteinuria, CKD, hypertension, and even hyperfiltration, which may lead on to CKD. So remember, if a patient has AKI, you should definitely follow for proteinuria, for serum creatinine, blood pressure in these patients, definitely. So they do need follow-up. This was one of our study where we looked at almost 2,000 children who underwent cardiac surgery, and we found that out of those 2,000 children who got AKI, we did a biomarker evaluation in 44 patients. And we found that in 44 patients, they had high biomarkers. Now, listen to me carefully. Proteinuria had improved. Creatinine had improved. But still, at a follow-up of almost 40 months, they had a high urinary biomarkers still going on, even for months. So students, we need to follow up because they may have some ongoing inflammation which may put them at need for AKI, for CKD later on in their life. So you need to follow them. So over the last 10 years, multiple new advances have happened in the stage of AKI. We talked about the RAI concept, and we talked about the PCRRT group, and Dr. Rupesh leads the PCRRT iconic group with us, and we do a lot of academics and research in this area, and you will very soon see more recommendations from our group. And we talked about today landmark studies of the Neonatal AWAKEN group, the AWARE group, and remember that now please do look at the PCRRT guidelines. Most of them are freely available on the web. Do look at our website called pcrrt.com, where we have some free guidelines for you. And almost 10 years back now, we published a handbook on critical care nephrology, followed by a handbook on point of care ultrasound and transplantation. So I would recommend all of you to check the website. If you have any doubts, I'm still here, and Dr. Rena is also here today. Please feel free to ask us any doubts you have. Thank you.
Thank you, sir, for the wonderful discussion. I think it was such an enriching experience for all of us also to hear. Hello? Hello?
Yes, we can hear you.
So thank you very much for such a enlightening and enriching experience. We really were very elated to know so many studies. I would request Dr. Rana is there with us. Before we take questions, if he's there, we can ask his expert opinion. Okay, once he joins, at least, sir, there are a few questions for you in the chat box. So, Dr. Anupma has asked, is there separate peritoneal dialysis fluid for neonates available? Which one? How can we make PD fluid for neonate in case of non-availability?
So PD fluid is available. The same PD fluid we use for neonates also. However, remember that if you have a child with lactic acidosis, inborn error of metabolism, then you need to make a fluid. So there is a formula for that, but usually that is not needed unless you have a patient with severe lactic acidosis. Okay, so we use usually the same PD fluid. Now, a formula for eGFR for neonates, we don't have a formula for eGFR for neonates. Remember that we use the same formula, the same definition of eGFR as per your conventional neonatology books. So we don't use any formula. So remember, if you have of course, newborns have a very low GFR. So anyway, the dosing of antibiotics are done as per their GFR only. Okay, whatever dosing you use as per your Harriet Lane, they're all done as per their GFR only. Okay, thank you.
Wonderful. Two things that were, I think, very keen, very clear from your slides was fluid overload, which I think we should always look into every ICU, every patient admitted in hospital. And second was high risk situations that we need to figure out. Dr. Dheeraj Shah is there. Sir, you are there. Hello, sir. Good morning, Dr. Lalit, sir.
Hello, good morning, everyone. It's such a nice discussion. Very nicely make up. Sir, actually, Doctor, I want to know from the panel, clinically, can you make out the renal shutdown is because of ATN, and how common is ATN in India? What are the common scenarios in which you suspect कि इसको ATN है या कोई और renal shutdown? Of course, we always see pre-renal. We are careful. We said you should always be careful before it goes to acute renal injury. So how common is ATN? How can we suspect that this child is part in among acute renal injury? This could be ATN, because most of the time ATN has got of course the treatment modalities are the same.
So, do you want to answer that, Dr. Rupesh?
So that's a very good question, and I wish we have a magic wand which we can just give it to you and say this is ATN. It's a very clinical, it's a very defined phenotype in the patients when you see ATN. So let me clarify one of the concept is pre-renal going to ATN, you just have 6 to 8 hours of either intravascular volume depletion versus hemodynamic perturbation versus nephrotoxic exposure. So clinically, what you can always use the terminology for the ATN is, which is a very good surrogate marker, is if your all the parameters, basically your blood pressures, perfusions not getting better after the fluid challenge of fluid resuscitation, the time elapsed between pre-renal to ATN is 6 to 8 hours. You're dealing with ATN. And urine output is a very good surrogate marker for acute tubular necrosis. Now, ATN is not an endpoint, it's a process. It goes on and it involves the tubule damage and regeneration. So technically, if you're in a sepsis or septic scenario, it is ATN because of multifactorial. Or if you're dealing with any kind of infectious etiology, in the setting of HUS. These are the things that causes not only just the tubular, but also chemokine activation and caspase activation and causing the tubular damage. So today people say pre-renal. I will assume the pre-renal going to ATN will not take anything about 8 hours after that. You are dealing with the ATN. There are urine indices and all, but I think urine output is a very good surrogate marker, and no response after the fluid and augmentation of the urine output could be leading to the ATN. Does that answer your question?
And which is the commonest cause in childhood? ATN.
For ATN? There's no common cause. It's just you have no renal perfusion, and anything can do that. Whether it's infection, whether blood pressure, whether intravascular volume depletion, pre-renal to ATM.
And
So
among
there's no
the
specific cause.
among the nephrotoxic drugs,
Which is most common?
yes, ATM.
It looks like a rapid fire question going on, but I can
No,
say
no.
that vancomycin and gentamicin or aminoglycosides
Because they are
combined with
commonly used. They're
yeah,
commonly used.
Zosyn and vanco is the worst combination if you look at the ninja study.
Dr. Rupesh, there's a question in the chat box. In case of pre-renal AKI after 1 or 2 fluid boluses of isotonic fluid, are we correct in giving a bolus dose of furosemide, so-called to open up the kidneys, or is there any change in the practice here?
I'm very happy that whoever has put that question. So I think we're talking about the furosemide stress test.
Yes.
And FST is very, very good. But one thing I want to make it very sure that don't make oligoanuric to non-oliguric by giving the diuretics. There are multiple studies. There are actually a meta-analysis because it's a bad omen and it's a bad way of treating it. What furosemide stress test tells you is basically is whether your tubules have a capacity to regenerate or you're not at the phase of complete tubular necrosis. There is change in mainly in the glomerulus with hemodynamic perturbations, or you're talking about efferent versus transglomerular pressure. So what does furosemide stress tells you is when it acts on the thick ascending loop of Hanley, that's the maximum partial oxygen pressure that you use there. You inhibit that, you have a generation of the urine output can augment. So furosemide stress test, I don't know, Siddharth, if I'm wrong, sensitivity is low, but specificity is actually higher. But they're not about like 90, but they're around 80. So yes, you give fluid challenge, make sure you resuscitate it well. Couple of things you have to be careful is JVP doesn't work at all, or CVP does not work at all in children. So it's very hard when they're intubated. See, the perfusion is good. Boluses are given good. I do not believe on isotonic. I'm very much beginning to follow renal lactate as my resuscitation. And that's what the SAFE trial has shown. And then you can try it. They open up. One thing is you have to know, I think it was Dr. Mendirata was asking, the kids are very naive. The tubules respond in a very different directions. And be careful with the neonate because the tubules channels are not developed very well either. So yes, furosemide stress test has a lot of efficacy. And actually it is now, we are doing it in adult as well. And I have personally seen it's a very good thing to see whether you are at the verge of complete tubular necrosis versus you are in the gray zone between pre-renal to ATM. I hope that answered the question.
Any other viewpoint you want to share with our students, since you are a teacher for both adult and pediatrics? So we have lots of students here, DNBs as well as pediatrician. So having some wisdom of pearls from you.
So first wisdom of pearls is make sure that your better half has a lot of patience because it took me 11 years to train. I did my med peds for 5 years and I did adult critical care 2 years in Cleveland Clinic and 2 years I did it in Rainbow and 1 year was my training for the K-12. I think two or three things I'll tell to these Gen Z. I will call that Gen Z. I think we are more on our old generation too. Is number one, have patience. That's number one. Number two, be honest and have some perseverance. It will take some time. Today we have Dr. Dirsha, we have Dr. Dinesh Kumar, we have you, we have Dr. Ajay Kumar. We have done a lot of time to reach to the level we are. I think short gains are very short, it not last too long. So work hard, be consistent, give some time, and have patience. Everything cannot be a fast pace. If you do that, you won't learn. I'll be very upfront and I say that it takes me a lot of time to come and develop this kind of authority. It takes time. The problem is you cannot be in an earlier career in 1 or 2 years and you think that you will go on. to a higher level. I'll give you a very short example. And the last thing is to have a very good mentors in your life. And mentors are so important in your life. And I'll give you an example. One time I got a call at 6:30 a.m. from my mentor who knows me when I was an intern. And his first question was, I know you're angry. I said, yes, I am. And he said, who will apply for this position at the age of 47 years? Even at the age of 65, I'm debating to go for president for such a high society. So withdraw your name. So that was my learning lesson is do not act fast. Do not be preemptive. Give yourself some time. And once you reach to that level, maintenance is very hard. For me, it is very hard. For Siddharth, is hard. Same with Dr. Dheeraj Shah. So you reach there is fine, then you have to maintain it too. That's a tough part. Reaching is a curve, and then maintenance is a plateau. To be in plateau, you need more, I will say, patience, and then you start developing the mentees, which is you have to give back to the community. So those are some of the things and I really want all the juniors to read. We have published a paper in JASON that came out. Its maximum read is how are we going to talk to these Gen Z and teach them? But I think you're lacking patience and you want to climb too fast. So that's not a problem. You can reach there, but you will not sustain for long. I don't know, Dr. Dheeraj Shah, you want to say some word of wisdom, or Dr. Ajay Kumar Gupta?
No, it's really true, sir. As they say, Taj Mahal took 22 years to get built up. So nothing happens
Right.
overnight.
Right.
So one has to work very hard and diligently. And we have Dr. Dheeraj Shah with us. He has been a great mentor for us. We request Dr. Dheeraj Shah again to say a few words.
Thanks, Dr. Siddharth. It's always a pleasure to listen to you and see your research work and using our own. I think we all must learn how to two things from Dr. Siddharth, Dr. Rupesh, and his team. Then I'll come to the subject. One is that how to generate. We keep on saying that we don't have enough evidence in India or we don't have enough local evidence to support these guidelines. So this is how you can do that. It's not somebody else will do for you. So we are people, we have to, I would say, validate the evidence which has been generated elsewhere, or we have to generate our own adaptation or our own new guidelines, criteria, which would be valid in Indian setting. So that is what Dr. Siddharth has always done with. And the second thing we need to learn is how to collaborate. And he has always made a team of people. He has involved people who have done exemplary work or phenomenal work in the setting and involved that team in the research and formulate our own guidelines, criteria, adaptation, whatever you may call it. Regarding the subject, I think he has beautifully covered right from what are the important critical steps, right from the early suspicion to early diagnosis. And as I said in the beginning, in well-looking children, in critically ill children, and where to intervene, what to do, when not to intervene, and especially the last part where you covered the recent advances as well. Again, in the recent advances, he had his own, I would say, review which would be very useful for students to answer the theoretical questions as well. And I'm sure that some of these important recent advances would be forthcoming in India in maybe few years. So I think it was a great learning from this seminar for all of the, not only for postgraduate students, but also for people who have interest in nephrology or maybe pursuing their early career in nephrology as a DM student or a FNB student as well. So in the nutshell, AKI is a common problem, whether it is a critically ill children admitted in ICU or neonatal unit, or children who present with renal problems like oliguria, hematuria, cola-colored urine. And it needs to be diagnosed early because it may be too late if you just keep on neglecting it, don't do a renal biopsy or don't refer especially the acute tubular necrosis and concentric glomerulonephritis. These are the two conditions which need to be taken care of early. Otherwise, it may progress to chronic irreversible fibrous injury. And the diagnosis, the management, if I think he very importantly say, do what you can do best. If you do not have the facility for hemodialysis, either you refer to the earliest nearest center, or if you cannot do it, you can learn how to do peritoneal dialysis, use soft catheters, which are now, or maybe in your setup, you procure those machines which can take care of many of the earlier issues which were related to sepsis, and also to repeated interventions, repeated in and out cycles. So I think in the nutshell, a very beautiful, very comprehensive session on acute kidney injury. And thanks Dr. Ajay Kumar Gupta, Dr. Ravindra, all the IAP daily team to organize such a important or lectures or webinars on such important topics. Thank you so much. It was a pleasure to see you, Dr. Rupesh, and especially thanks for staying with us. Maybe it's 12:30 midnight with at end.
Thank you, sir. Thank you, your word of wisdom. And thank you, Dr. Rupesh, sir, from joining USA.
Thank you.
And thank you, Dr. Siddharth Sethi. Now, it's a
Yes.
wonderful session. And I think one of the most knowledgeable session till today and what I learned. And now I request our Treasurer cum Secretary-elect to say a vote of thanks. Dr. Ravinder, sir, please.
Thank you, Dinesh, and thank you all for a very crisp talk on AKI. Yes, I mean, nowadays and recently, it has become a very important topic in our day-to-day practice, right from the neonatology to pediatrics. So thank you all. Thank you, Dr. Neha. Thank you, Dr. Dheeraj Shah, for crisply summarizing everything. Thank you, Dr. Siddharth, Dr. Rupesh, Dr. Suchita, Salvaya sir, and Lalit. And in the last, thank you, Dr. Ajay, for continuing this legacy of our mastery class. Thank you all. Thank you.
Thank you. Thank you. Thank you, Dr. Patari. Thank you, Dr. Sethi. Bye-bye. Good night.
One last question. I think we'll just take that question. Dr. Siddharth, do you want to answer this question?
Okay, so the question is, what is the maximum dose of furosemide IV and infusion, and when do you use it? So we have commonly used furosemide infusion in refractory fluid overload, even in nephrotics also. And I would say usually we don't go beyond 0.5 to 1. 1 is actually the maximum dose, milligram per kg per hour. So usually used in refractory fluid overload, and we use it all the time in nephrotics who have refractory edema. But use it with caution, okay? Thank you.
Thank you. Thank you. Bye-bye.
Thank you, everybody. Thank you, Dr. Neha. Thank you, IIP Delhi. Thank you.
Thank you, Dr. Siddharth, Dr. Neha, Dr. Dinesh, all.